Welcome, everybody. This is going to be the 5th session of the Global Response to COVID-19. This meeting is sponsored by the Panamerican Trauma Society, the American Society for the Study of Trauma, International Relations Committee, the World Coalition for Trauma Care, and supported by the University of Miami and the Virginia Commonwealth University, VCU. I'd like to welcome our panelists, our attendees. I'd like to say this meeting has been recorded, so just join this meeting, you agree that this meeting is going to be posted to our website for our societies. Also, please do not make any comments, political comments, or do not talk anything that could not be recorded, could not be shown afterwards. And also, please be sure that we're going to answer all the questions. So we're going to do a different way today. We're going to have like a pool of questions. We have 2 presentations today, and then followed by 4 pool of questions on where everyone should be able to interact and answer the questions. And afterwards, the panelists are going to comment on the results and the experience. So Dr. Aboutanos, chair of the WCTC International Relations Committee, are going to introduce the international panelists.
Hello, welcome everyone. So we have, again, like Dr. Marttos said, there's going to be audience participation, and all these panelists will be receiving the questions. We'll be able to ask them the question after the audience responds. So it's a pleasure today for us to have our various panelists. As always, it's an honor to introduce Dr. Coimbra, who's the founder and executive director of the World Coalition for the Trauma Care, Surgeon-in-Chief at Riverside University Health System Medical Center, and Professor of Surgery at Loma Linda University School of Medicine. Same time, we have Dr. Beaufort is back with us from South Africa. Dr. Beaufort is the trauma director and academic head of the Mill Park Hospital Academic Trauma Center, as well as Professor Emeritus of the Department of Surgery at the University of Witwatersrand. We also have today Dr. C, member of the AAST International Relations Committee from Auckland, New Zealand. Dr. C is a service clinical director in general surgery and consultant of trauma and acute care surgery, and we are thrilled to have him here. We also have, again this week, Dr. Alan Guo from Buffalo, New York. Dr. Guo is a professor of surgery at Sonny Jacobs School of Medicine and Biomedical Sciences. And I think these are our main panelists for today.
Thank you, Michael. Now I'm going to ask Dr. Raul Coimbra for please welcome all the other associated and affiliate societies from around the globe.
Yeah, so once again, on behalf of the World Coalition for Trauma Care, WST, my University of Miami, VCU, and the Pan American, we would like to welcome all the participants in the panel, all the speakers, and all the attendees. This is quite an accomplishment. You can see on the screen the number of professional organizations that have joined this effort. And suffice to say that we are all in this together. So thanks for joining.
Thank you, Dr. Coimbra. And now, Dr. Aboutanos, please introduce the first presenter, and we're going to start. Thank you.
Yes, our first speaker and presenter is Dr. Ali Jafarian, who hails to us from Iran. He is the founding chief of the Division of Hepatopancreatobiliary and Liver Transplantation at the Imam Khomeini Hospital Complex in Tehran. He's also professor of the Department of General Surgery of the School of Medicine of the Tehran University of Medical Sciences at Tums. So welcome. It's a pleasure to have you here and get a feedback on the status of what's going on in Tehran specifically. So we'll switch to Dr. Jafarian. You need to unmute yourself. Yeah.
Thank you very much, Dr. Aboutanos, Dr. Marttos, and all of the panelists in this great webinar, which I think is the 5th one. Thank you for the great job that you are doing. And thank you for this time that you made it for us to present what is going on in Iran and in our hospital, which is the largest one, and I can share with you what we have done in the past like 52 days from the beginning of the epidemics in Iran. If I could have my slides here, and thanks to Valeria, who is doing the job very great and very good. I'm going to talk about the trends and the treatment of COVID-19 in Iran and the world. And we'll have three parts. The first part is an overview on the epidemiology of the disease in the world and in Iran. And then what we have done in Imam Khomeini Hospital during the first 50 days of the epidemics, and then what are the treatments that is done now, and then we will be open for the discussions and the comments. If I have the next slide, please. If we go to the world, according to the reports that you can see here, we have the total cases and total deaths on the left side of the image. We have passed from 2 million cases in the world, and as you know, more than 126,000 deaths. And if you look at the right side, this is the logarithmic curve of the total death and cases, which is still not downward, it still is going up. And if we go to Iran, the next slide. May I have my next slide? Yeah. If you see here, there is a difference in Iran. On the left side, you see the total cases and total death in a logarithmic curve. As you see, we did not have a very high-peaked spike, but still it is not downward, and even it is not still a plateau now. And if you look at the right side, the daily new cases is going downward. And if you look at the dates, in 29 of March, which is the time that the government started the lockdown here, you can see the effect very soon after that. Before that, we have a special situation in Iran, and that was the March 20 is the first day of New Year in Iran. So if you see the time of March 1920 in the upper quadrant of this image on the right side, you see after that we have the upward slope, because we had some travels in the country, and it was not a real closure of everything. But afterwards, in 29 of the March, we had the lockdown, and you can see the effect of lockdown. And if you see the lower corner on the right side, you see the daily death, which is going to be a plateau and slightly downward after the lockdown. Let's go to the next slide. And this is the work of one of my colleagues who unfortunately couldn't attend this webinar tonight. I hope he would be later on this, Dr. Younesian, who is a professor of epidemiology. This is the doubling time of the disease from the beginning, which was the February 20th. In Iran. And as you see, in the first 2 weeks, it was very high, like 1 or 2 days. It was doubled every 1 or 2 days. And then the schools and universities and everything was closed at this time. And then we went to the beginning of the new year. Until that time in the new year in Iran, which is the March 20, at this point of the first peak of the curve. And afterwards, so the doubling time was lowered less than 10, we have the doubling time again of 7 or 8 days. And afterward, after the lockdown, which was on March 29, you see the upward slope, and the doubling time now is more than 25 days, which shows the effect of lockdown. And now the next decision is how we can manage the lockdown. I will mention on that. Next slide, please. Our university, which is Tehran University of Medical Sciences, is located in Tehran city, the capital city of Iran. We have 15 hospitals with a total of 5,000 beds. So this is a large university with dedicated hospitals. We have 1,800 full-time faculty members, more than 1,000 are clinical. And we also have 2,500 residents and fellows And the population that we cover is 2.9 million for primary health care. In Iran, the health services are integrated to the medical universities. So each university has a geographic area. For ours, it is the southern part of the Tehran. So, and the population is under the coverage of the university for the public health issues. Next slide, please. The Imam Khomeini Hospital, which I work in it, and I'm representing the work of my colleagues there, is the largest university hospital of the country with 1,200 beds, working since 1947. And if we go to the next slide, this hospital is at the center of the city in a large area of 25 hectares. If we go to the next slide, at the right upper corner, you see the map slide. Yeah. On the right upper corner, you see the map of Tehran. The city itself has like 8 million population, and the province, which is not geographically too larger than this, has a 13 million population. And this red point in the right upper map is the location of our hospital, which you can see in the left photo from the Google Earth, and the hospital building, which is built by German engineers during the World War II. Now, in this hospital, we can go to the next slide. What we have done in the past 51 days from the February 20, which was the first day of the epidemic in Tehran, we have seen more than 17,000 outpatients in our triage clinic, and the admission rate was 9%, which is 1,600. Next slide, please. This is the curve of the daily triage visits. We reached to the around 800 each 24 hours in the first week and the second week. And afterwards, slowly we came down. Now it is usually less than 200 visits in the triage per day. Next slide. My colleagues arranged a setup of 5 lanes in this triage visit, so they can manage the patients and the triage visit area was out of the hospital, out of the main building. It was in the campus, and a special area was built for that. So they can, after the first week, they can manage the patient to be triaged into 2 parts. One was the febrile and respiratory disease patients, and the other was the other emergencies. The daily admissions, again, as you see, was going up to this high of like 70 patients in each 24 hours. And afterwards, you see here is the 29th of March. And when you go to the slope is downward is after the lockdown was issued and was started. Next slide, please. And this is the daily death rate. At the beginning, the death rate was low because the patients were of better clinical situation. And afterwards, we had the problem with the ICU beds. We did not have enough ICU beds at that time dedicated because we had our own patients in the ICU facilities, and we have to rearrange the ICUs. And afterwards, the slope was downward, and now the average is less than daily ICU admissions is like 60 to 80 patients. So in each day, we have between 60 to 80 patients in the ICU beds, and the mortality is, the average per day is like 3 per day, 3 to 4. Next slide, please. And these are my colleagues in ICUs, 2 of our ICU. The right one is the open heart ICU, which is now dedicated to COVID patients, and the left one is the surgical ICU, again is dedicated for COVID patients. Next one, please. So what we have done is that we made we increased ICU beds to 98 by reallocating different ICUs. We make free modern 330 beds for COVID patients and 18 beds in the emergency. So a total of like 450 beds were allocated for COVID patients so we can arrange and manage everything better. Next one. So this is a very brief report of the first 4-week patients who were admitted. There were 870 patients. The criteria for admission was positive chest CT scan plus O2 saturation of less than 93% or dyspnea or comorbidities. So not everybody was tested before admission. The test was done after admission. And in the first days, we did not have enough access to tests for everybody. So just the inpatients could get the test. And now the facility is inside the hospital. We can do more than 150 PCR tests for the patients in the hospital. And we are going to do it for the staffs and everybody who need it. Next one, please. I just want to show a few tables of this study, which is under submission now. As you see, the men were more than 60%. As you see here, the ICU admission was about 10% for the whole population of inpatients. And if you go to the positive test, it is 13%. And the death rate was 10.8% in the whole patients that was admitted in the hospital. And if you see here, for the test positive patients, the death rate was 16%. Next one, please. And the rate of readmission, as you can see here, is 2.35. So our readmission rate was not too high. And you see some of the comorbidities here is not all of the comorbidities, but those that were more important. Next slide, please. I will go to the drugs later on. And I do not have enough time, I think, but I will try to be short. And here, if you see at the odds ratio, the adjusted odds ratio for mortality for all of our patients were, for the age of 61 to 70 was 8.7. And if you go to the test positive patients, it was 10.47. And for the age of higher than 70, it was the adjusted odds ratio for mortality was 18.9, like 19. And for the test positive was like 22. And if you see here, as it's clear, the ICU admission was great, has a great odds ratio. Next slide, please. So in summary, we had 40% positive PCR tests in all of our patients, which is a significant point, I think. The ICU admission rate was 10% at the beginning and increased to 18%, and the mortality as a total was 10%. The ICU discharge rate was 50%, but for intubated patients, the discharge rate was 15%. So the management of ICU and the trying not to intubate patient very soon maybe was important in that. Next slide, please. I will go rapidly through the treatments. Next one that is now done done here. As you all know, the hydration, nutrition, rest, oxygen, acetaminophen or paracetamol, and if not responsive, the high fever or myalgia, naproxen was added, and hydroxychloroquine was started for everybody. Anticoagulant as a prophylaxis was done routinely, but at the therapeutic level was different protocols. In some ICUs, my colleagues are using it for everybody who is in ICU using therapeutic anticoagulants like heparin. We have some evidences of hypercoagulable state, and also we have some evidences as intrapulmonary hemorrhage. So it is, a dilemma here that always it is useful or not. Next one, please. About the antiviral treatment, now our routine is atazanavir for the first line. If not available, or if this, according to the guideline of the Ministry of Health, Caletra is okay, but they have to lower the hydroxychloroquine because of the complications. Ribavirin and oseltamivir was used at the beginning, but now it's discontinued. Other antivirals like sofosbuvir, remdesivir, favipiravir, all are under trial, some in our hospital and some in others' hospital. Next slide, please. Other measures like CRRT and hemoperfusion and plasmapheresis are not done routinely for very ill patient. They are done as per indication if there is. We have other drugs like tocilizumab, which was not continued because of severe side effects. Azithromycin is under trial now. Arbidol is under trial in our hospital. Anti-TNF is under trial in our hospital. Interferon beta is under trial in another hospital. Next one, please. About the respiratory support, my colleagues are very pro to the NIV as soon as the patient is hypoxic, and they did not wait for it to patient be too ill. We have no experience on prone ventilation because of the equipment and the respiratory therapists that we need for that. Intubation is per indication, and if the patient is intubated for more than 1 to 2 weeks according to general condition, our intensivist did usually percutaneous tracheostomy, and we have some patients who are discharged after tracheostomy and recovery even after 20 or 30 days. Next one. Other measures like IVIG was used but is not continued so much. Transfusion of convalescent COVID-19 plasma is under trial. Other hospitals has used it and they have hopeful results. Methylprednisolone pulse is used if there is inflammatory storm, no sepsis, and the interleukin is high. They use the methylprednisolone as a pulse. We have some trial on mesenchymal stem cell to increase the lymphocytes, not yet any special result. And vitamin C also is on the trial, which is not going to be as useful as thought from the beginning. Next one, please. And I'm going to close the presentation here. The last word that I got from all of my colleagues in the intensive care units is that the coronavirus is doing its job, and the most successful treatment we have experienced till now for severe cases is real intensive care. What we need is intensive care. None of the drugs has been proved to be so effective other than intensive care. So we need a real intensive care. That means it is not just equipment, it is not the ventilator itself. It is a team who is very well prepared for this. Thank you very much for your hearing, and I hope that sharing this, we can go to the next slide, which is the end one. And I hope that this information would be of interest and could be discussed later on. Thank you.
Thank you, Dr. Jafarian, for your great presentation. We're going to discuss your treatments, your findings later. Now I'm going to go right away to Dr. Rafael Barrera. Dr. Rafael Barrera is Director of Global Surgery and the Surgical Intensive Care Unit at the Long Island Jewish Hospital. He did a presentation already last week. I'm going to give an update about what's happening in his hospital from last week to this week. And then after his presentation, we're going to have everybody answer some questions. Dr. Barrera, welcome. Thanks for being here again. We want you to hear your updates, please.
Oh, can you hear me? Yes?
Yeah.
Okay, thanks. Next slide. I'm just going to give an update from last week. If you remember, as everybody recalls, that Long Island Jewish is right on the border between the city of New York City and the suburbs, and we took the brunt of both the city and the two counties adjacent. Next slide. Last week, as you can recall, whoever was paying attention, we had 711 inpatient COVID positive patients, 152 ventilators. We usually have 50 ICU beds. As of yesterday, we have 723 COVID positive patients, 110 ventilated patients, 2 on ECMO. Of the discharges, 12% of the patients on vents have been discharged from our hospital. And as of today, we have discharged 1,006 patients with COVID positive. So it's very positive news from LIJ. So that's Long Island Jewish Medical Center. Next slide. This is from last week, from the 7th. As you can see, the curve is still going up a little bit, and we had 700 patients in-house. Next. The next slide shows us, as of yesterday, that the curve is coming down and we have less admissions. And what the problem that we are facing now is that we have close to 600 patients in-house that are either getting better or slowly deteriorating. That's why if you see in the next slide, we see that as of today, the curve is completely flat and going down. The issue right now is, this is the slide I was looking for. You see it's flat and coming down. Admissions are less issues. The next slide, as I was telling you, the issues right now are what we call the rapid responses are increasing dramatically. Next slide. And the intubations on the patients that are not doing well are increasing. The anesthesia team is basically now deciding to intubate between 5 to 6 patients every 12 hours. And what has happened is that we have implemented the ethics palliative care committee to try to avoid a lot of unnecessary intubations in patients that are very frail and will not survive intubation. Next slide. This is the slide of celebrating 1,000 COVID patients discharged as of yesterday. The house was very happy, and it was a morale booster for us who have been working with the nurses. The nurses right now are 3 to 4 in taking care of 3 to 4 patients per shift. And the last slide, this is the algorithm that we're using to call the ethics palliative care consult in the patients that are questionable, that have questionable survival, and that might need some a very specific talk to the family or the healthcare provider, healthcare proxy, to avoid unnecessary intubations and unnecessary trips to the ICU. So overall, my update is very positive. I think we're past the worst, and now we just have to deal with the patients that are in-house to see who is going to go to ICU and who's going to survive. Thank you very much.
Thank you, Dr. Barrera. Great presentation as usual. So now we're going to go to a different part of this webinar, okay? So we're going to have 4 pools of questions. So Valeria is going to launch the first pool of questions, and the pool number 3 and 4 are more about treatment. So let's go fast for pool 1 or 2. But everybody going to see the pool number 1, and please answer the questions. So Valeria, can you launch, okay? So we're going to see the questions, then we're going to go to next. First one, is your country on lockdown? Just say yes or no. Go to the next one. Are the healthcare providers or facility wearing PPEs, protection masks all the time? Yes or no, or a no. Let's scroll down or go to next. Does your facility currently have any COVID-19 positive patients? Yes or no. Question 4, does your facility have intubated patients on COVID positive? Yes or no. These are the basic questions, just to understand what's happening around the globe. Number 5, has your facility had any patients that attributed for COVID-19? Yes or no. Number 6, how are the numbers in your area or facility? Still increasing, slightly increasing, not increasing, it's plateau, decreasing a little bit, increasing a lot, or you don't know. So please answer that. And the last question going to be, what kind of test is your facility using to diagnose COVID-19? At the end, you need to click submit. Okay. After answer all the questions, please click submit. And I'm gonna give you a little more time, so everybody can answer this. Then you're gonna see the results on our screen. Okay, I think we are fine. Valeria, can you stop the pool and let's see the results? So let's see the results. Dr. Coimbra, you're probably gonna be able to see the results. Can you make some comments, please?
Sure. Interesting. 78% of the respondents live in a country or an area where lockdown procedures are in place. as we saw in the two previous presentations, the importance of instituting lockdown and social isolation measures. Unfortunately, 21% are still not doing it. This question is a little tricky, number two, because it says, are healthcare providers wearing PPE at all times? And I think the split here is 60 and the rest 40 is based on the fact that some people that are not in COVID positive areas and are not in the front lines are not because they don't have to. But I'm sure that 60% represents those that are in the front lines. A few people on the audience have not seen any COVID positive patients, which is, it's interesting. Most of us are dealing with this right now. If your hospital have intubated patients, yeah, so it matches the previous answer 3 and 4. If you've seen it, you've seen people intubated because a significant number needs to go to the ICU. And if you've seen them going to the ICU, you've seen them dying because the ICU mortality is much higher, and several studies have shown that ICU admission correlates with, it's a strong predictor of mortality with a significant odds ratio. And the epidemiology is different from place to place, and most of us are still seeing a slight increase in the total number of cases. I can speak about California in particular, although in many counties in California, we are still seeing a slightly increase in the total number of cases because more testing is being done. It seems that our curve has plateaued, and the mortality trails the plateau curve in terms of hospital admission. So more people are positive, less people being admitted to the ICU, and mortality will trail that probably between 10 days to 2 weeks. And most of these tests are non-specific for COVID, but people see different value in each one of them in terms of procalcitonin, associated bacterial infections, IL-6 levels to determine when the cytokine storm happens. C-reactive protein is obviously the most commonly done, as well as ESR. So I think that the practice has been pretty much heterogeneous regarding this test, depending on where you are on the curve, depending on where you live and the resources of your hospital. That's all for me.
Thank you, Dr. Imbra. Dr. Aboutanos, would like to ask our colleagues from New Zealand and from South Africa about what's happening with their curve, and also maybe number 7, what kind of tests are they using? Dr. Aboutanos, please.
I'm glad you mentioned that, because that was my first question, was going to Dr. C for him being up at 4:30 in the morning. And I got the email that he and Dr. Ian Civil sent with regard to the lockdown in New Zealand. Do you want to comment on what you guys have seen very quickly, Dr. C? Did you see the same thing that Dr. Jafarian mentioned with regard to the dramatic differences once you have lockdown?
Yes, thank you, Michael. Thank you, everyone. Regards from New Zealand. Our first case, we only got our first case on the 28th of February from a traveler into New Zealand. And as of yesterday, we have 1,386 positive patients with 9 deaths overall. New Zealand is divided into 20 DHBs across the country, and every DHB has got cases with COVID positive. So we know that the disease has spread to everywhere in New Zealand. The New Zealand government has a 4-level alert system. Currently, we are on the highest alert, which is level 4. And our nation went into complete lockdown 3 weeks ago for 4 weeks lockdown. And our lockdown rules are fairly strict. Only essential travels. We are able to get to the hospital and back. We are able to walk in our neighborhoods. and going to get our groceries. That's about it. There are no beaches, there are no takeaways, there are no restaurants. Everything is shut. The streets are quiet. And the border control is strict. Only New Zealanders and residents can come back into New Zealand. And everybody, as of a couple of days ago, coming into New Zealand needs to go into a government quarantine area for 14 days. In terms of our deaths, we have 16 cluster of cases of more than 10 people across the country. And these deaths occur mainly from aged care facilities. There are 3 aged care facilities in New Zealand are affected. And these elderly patients, unfortunately, succumb to the disease. We have about 100 healthcare workers tested positive in New Zealand. There are 13 patients in across New Zealand hospitals with 5 patients in ICU. Our infective rates, about 50% are from contacts with a known case, and about 35–40% are from patients coming from overseas. And we have, it's estimated that our community transmission, there are 28 areas. So we see that the number of infected cases are declining, and we have reached our peak about a week ago. But still, we think it's still early days. Our case fatality is 2 per million. And interestingly, just a little bit about Australia, Australia is in a similar situation, similar lockdown situation, but the rules are a bit different. They have 6,416 cases as of yesterday, with 61 deaths. The case fatality is the same as New Zealand, 2 per million population. We, in our hospital, we have spending a lot of time preparing for our ICUs and surgery admissions. Unfortunately, we did not see this happening in my hospital. Although currently we have inpatients, COVID positive patients. We have an increase in healthcare. We're going to increase the healthcare testing, and we have broadened the definition for testing. And there is a testing on site at our hospital for those of us who work in the hospital, should we develop COVID-like symptoms, so we can have an idea of where we are at. I think the difficulties here is moving forward as well. Not quite sure what New Zealand government strategy is going to be like after the lockdown. I suspect there's going to be further restrictions, maybe to a lesser degree. However, we have only had 1.1% of the population got tested in New Zealand, and hopefully this will expand. There's a talk from the government that we should get surveillance testing as well, and random testing for the population to get a more accurate idea of where we are at regarding the epidemiology across New Zealand. Thank you.
Review, especially from both New Zealand and Australia. We're just going to have Ken, Dr. Beaufort, can you, because you also had lockdown, can we have you comment on that before we go to our next batch of questions?
Yes, thank you very much. We're kind of behind. We've had more notice than almost anybody else. We're seeing 3 peaks. The first person that we got who was positive came from North Italy on the 4th of March. Party of 10, all from Northern Italy, 8, but not the 2 children, tested positive. The first local transmission we picked up was on the 12th of March, and South Africa went into full lockdown on the 14th of March. That is 12 days after the first case. And I think New Zealand and Australia have it slightly easier than we do, because full lockdown meant just that. No one outside their property, no one allowed to walk the dog, no exercise, no jogging. The army and police are out in force. There is up to a 6-month jail sentence for breaking that. And interestingly enough, no alcohol or cigarette sales permitted under any circumstances. For Dr. Coimbra, as a trauma surgeon, what it has done, slightly tongue-in-cheek, is that South Africa has about 1,000 trauma deaths per month, and we're fewer than 250 this month. So indirectly, the lockdown has saved something like 750 trauma-related deaths over the last month. We have got 6 weeks grace on anybody else. The lockdown will be 3 weeks this Thursday and has just been extended for a further 2 weeks to 5 weeks. Now, there are the haves and the have-nots. The have-nots are living in very crowded accommodation, up to about 10 to a room. We have a large number of homeless, and one of the things our government has done is established significant facilities for our homeless people, where there is some degree of separation and so on. Despite the overcrowding, despite the fact that gatherings more than 50 are prohibited but sometimes broken, and there is no traveling between regional borders, you may not cross a state line, again with the jail sentence behind you. Our staple transport is the 16-seater minivan, which is currently restricted to 10 seats, and a car is restricted to 2 passengers maximum. End result, after 6 weeks, we have, with a population of 60 million, 2,500 positive cases. The government has set out, with community health workers, we have 28,000 community health workers in the communities doing screening followed by testing, and that is happening as we speak. In the last 10 days, they have screened over 500,000 people, again, like New Zealand, about 1%. Of the 2,500 who are positive, we have had 27 deaths, mostly elderly, mostly with related, but not entirely, comorbidities. So we're really at the beginning of that curve. And I think we will have good figures in terms of deciding to lock down or unlock down. We're using the R0, R1. For those, I think most people are now familiar with it, where the lockdown is dependent on the number of transmitted cases. And we are expanding at the moment by nationwide, in a population of 60 million, somewhere between 49 and 89 cases nationwide per day, primarily in our 3 urban centers, Durban, Johannesburg, and Cape Town. At the moment, all our hospital facilities for the moment are very underused. There is a triage at most of the hospitals into patients who present but have no areas of suspicion, patients who needed to be screened and perhaps be under investigation and overt positive. So I think it's going to be a case of we're learning from everybody else. We use procalcitonin and C-reactive protein on almost everybody who's entering into the hospital. We have a shortage of tests. We have patchy PPE availability, from absolutely outstanding availability to theft of PPEs. We have the banking community, which made a bigger offer. So medical services sometimes don't have PPEs because the banks remain open. And some essential services are the same way, but otherwise pretty much mimicking New Zealand. I think we will be able to tell in a couple of weeks whether our 12-day from first case to lockdown has made the difference that we have, particularly to our underprivileged population.
Thank you, Dr. Beaufort. Thank you very much for your comments. Let's go straight to the next pool of questions. So Valeria, please launch pool number 2. And let's go. Everybody going to receive this on your screen. First question, are you treating a patient intubated with proning? Are you proning the patient that you have been intubated, yes or no? Second question, how do your patients do with proning position? They worse, they're getting worse, no change, or they are improving? Okay, question number 3. Are you treating COVID patients not intubated with proning position? I start proning patients when they are not intubated. Do we start early or not? I know that Dr. Barrera answered this question last week. And another question. So, are you treating COVID positive patient with ECMO? Are you putting this patient on ECMO? Yes or no? And how do you see the response to this patient while they are on ECMO? Another question. Are you treating? What kind of strategy are you using for treating this patient? Like the standard ARDS treatment, high PEEP, low volume strategy. Is this helping the patients or not? And question number 8, are you guys doing tracheostomy on COVID positive patients? Are you just not doing 20 positive patients with COVID tracheostomy? Number 9, if you are doing, when are you doing these patients? Okay, early tracheostomy, later tracheostomy, or we don't know yet. Okay, so please click all the question, and then you're gonna submit when have all. We'll give some more time. Okay, 30 more seconds. So in this pool, we're gonna have questions regarding some strategy for critical care, proning or not, ECMO or not, tracheing, when you're gonna do trachs, on when to prone, only the intubated patients or the non-intubated patients, okay? Okay, Valeria, so, yes, any question?
Dr. Marttos, one thing I omitted, but may help other people. We are routinely now using thromboelastography to pick up hypercoagulation, and we are tailoring our anticoagulation because these patients do become hypercoagulable primarily on our TEG.
Yeah, this is going to be the next pool of questions. So, okay, let's finish the pooling, Valeria, and then Dr. Aboutanos, can you direct the questions to some of our international panelists, please?
Sure. So it looks like from the first question, you're taking COVID positive patients with prone positioning, and about 65% are doing that. You see that that's not universal across, and this is what we're experiencing. Now, the next one, of those who are intubated, are the majority being in prone position? And have you seen a change? And the answers are kind of everywhere because it's not uniformly used. And when it is used, you notice that between the slight improvement and significant improvement, it's still only about 20%. This goes again to what the Jafarian just mentioned, that you need a full ICU care, not necessarily relying only on one method. So that's consistent. To go number 3, are you seeing COVID positive non-intubated patient with prone positioning? I mean, are they self-proning? Are you helping them prone? And we have about 30% are doing that. And it's interesting, about 44% are unsure, but this may be another method for others to take a look at and consider after this presentation. And now question number 4, how do the majority of your non-intubated patients do with prone positioning, of those that do it? And again, the answer is not kind of 100%. You see some no change, although significant improvement are also noted in about 15 to 20%, but and still majority are not using this as a therapy. I wonder if the question will change next week or so when we do this again. Number 5, are you treating COVID-positive patients with ECMO? And we have about 30% are and about 50% are not. And this may have related back to our 2 previous presentations where we have noted that ECMO is not uniformly used by everyone. And of those that you use on ECMO, have you noticed any change? And those that have seen significant improvement are about 7%. Now, I don't know if that's 7% of those that responded or not, and still about 33% are not using it. But it's not guaranteed just because you use ECMO that you have excellent improvement, and you could see that from the answers. They're not uniform. Question number 7, does your facility have success with standard ARDS treatment, the high PEEP, low volume strategy? And again, the answers are variable. We have slight improvement, and about 18%, 15% seen significant improvement. But do notice about 9, 10%, actually almost 20% when you combine it, have seen either slight worsening to no change, and some still have seen worsening, which again denotes the fact you have to use different strategies as we've seen before. Then we go to number 8, are you performing tracheostomy on COVID patients? And we have about 44% said no, about 30% still saying yes. And so it's interesting how it's split. And on our institution, we're no currently. What about post-intubation day? Are you performing tracheostomy? At what day are you doing it? And again, we have people who are waiting even up to 28 days, about 7%. And contrary to what you believe, only about 10% are using it within the 7 to 14-day period. The majority are waiting at least 2 weeks to 3 weeks, it sounds like, when you put those together. And again, about 20% or more are never performing tracheostomy. But these are very nice sample to where everybody else is at. So Antonio, you want to go next to answering some of the QAs that are present that we have that are sent?
Yes, so let's go to some. So Dr. Barrera, regarding proning, when are you proning your patients? Only after intubation or before being intubated? When did you start?
We are proning patients before intubation. As soon as can you hear me?
Yes.
Yep.
Yes. As soon as the patient is admitted and if he becomes desaturating and they start worsening, we prone them and we give them steroids then. We have seen some success with this strategy. And sometimes even after we extubate a patient, we prone them extubated. During intubation, it seems that the patients, the first time they're proned, they do a lot better. And we have a number of patients that have been prone for 5 days, even a week, 16 hours on and the rest off. And in the off hours, that's when we feed the patients. And when they're supine, we sit them up and as much as we can, and it seems that a strategy that's been working.
Thank you. Dr. Coimbra, are you doing tracheostomy on your patients? Do you indicate tracheostomies on these COVID-positive patients?
So very controversial topic. We are advocating not to at this point, but I think the decision is local, is about logistics and related to resource utilization of all patients that we had in the ICU. I think we only did 1 tracheostomy, and the recommendations vary from professional organization to professional organization, but I think that most surgical professional organizations have recommended that if you're going to do it late, the early tracheostomy like we do regularly in the ICU for other diseases is probably not the safest procedure to do when virus shedding and aerosolization is very high.
Thank you, Dr. Coimbra. Dr. Guo, what about ECMO? Are you using ECMO in your institution? What about tracheostomy, please?
We have some ECMO, only 1 or 2, not so many. But I want to have a comment and echo Dr. Coimbra's answer. Can I share a screen for you? Okay, so I did give a talk here locally for institution here. I know from our survey here, the answer of the timing of tracheotomy is different from 1 to 2 weeks, 2 to 3 weeks, or no tracheotomy. This is from the American Academy of Otolaryngology. What they found was that we do not have any data for the COVID-19, but from the first epidemic, the data show that the mean time to death is 23.7 days. So that means prior to that, we really don't know if the patient is gonna do better or stay the same, or will be getting worse. So the ideal time for a tracheotomy should be at least 20 or 23 days, or 2 to 3 weeks. So if you want to do a tracheotomy, 1 week after incubation is way too early. So if you want to do it late, 3 weeks. And I also have a comment for it was from Dr. From Iran, Dr.
Jafarian.
You're talking about you're performing percutaneous trach in your ICU. Is that right? I mean, as of now, there's a controversy. People are talking about probably open tracheotomy is safer than percutaneous, because with the percutaneous technique, you need to do serial dilatation to expose the air, the aerosol from the trachea. I'm the one who is doing percutaneous, but in this pandemic, we should do open tracheotomy. And when you're making a hole in the tracheal ring, we should make sure that the balloon from the endotracheal intubation, the balloon should be below the incision we're gonna make on the tracheal ring to minimize the exposure.
Thank you very much for your comments. We're gonna go to the next pool of questions because we talk about treatments. Then I'm gonna ask a lot of questions to Dr. Jafarian and Dr. Barrera that has been heavy in the ICU, and other panelists to comment. Okay, Valeria, could you please launch the third pool of questions, please? All right. Question number 1: are you using steroids to treat these COVID patients? Yes or no, or unsure? Number 2: how do these patients respond after using steroids? Number 3: are you treating patients with chloroquine or hydroxychloroquine? This is $1 million question, right? So a lot of different results around the globe. Are you using hydroxychloroquine? Yes or no? How are the results? Are they improving? Are they getting worse? No change? Are you using azithromycin also or not? Are you using azithromycin to treat these patients? And did you see any change after you use azithromycin? So these are these pool questions. 6 questions about some initial treatment. Steroids, yes or no, and the response. Hydroxychloroquine, yes or no, and the response, and then azithromycin. And I know Dr. Baheri spoke about this last week, and Dr. Jafarian spoke about this today. So let's give a few more seconds so we can close the pool. And then we're gonna see the results, and then let's have the comments from the panelists. Okay, Valeria, let's close the pool. Dr. Barrera, could you please read the answer and then make your comments, and then Dr. Jafarian just after you, please. You are muted.
And I'll tell you what we're doing, and then I'll comment for the response. Yes, we're doing it early when the patient deteriorates, and they will continue in the ICU when they're intubated. It seems like 41% of the responders are using steroids, and the rest of the are not sure. So my question here should be, why are we not using steroids in some of the facilities? And I assume it's because they think the patients are going to do worse. But it seems that the majority are using steroids. And the second question, how do they do when they get steroids? It seems that the majority of people responded that there's a slight improvement. I am still not sure that they improve in the in our case. It seemed like initially they respond very well, but apparently there's a second wave that we're seeing the patients do better, and then after a couple of days they start deteriorating, and then we don't know if the steroids are helping or harming. But my suggestion will be that is a slight improvement, and I side with the majority of responders. The third question, are you using the hydroxychloroquine? It seems like everybody's using this. We are using it also. And I don't think there's a question about the usage of this treatment for the patients. The majority of patients treated with these patients, how do they respond? It seems that the majority of responders agree that there is some improvement. I will agree also. In my experience, it seems that this is one of the treatment options that the patients seem to improve with. Question number 5, are you using azithromycin? The majority of responders are using azithromycin. In our institutions, we are not. The infectious disease department think that it adds a little bit only to the treatment, and because of the severity of increase in the QTC, they opted not to use azithromycin, and 24% of the responders do not know. It seems like the majority of responders think that it is helping in the treatment of this disease being treated with azithromycin. I can't comment from my experience because we're not using it anymore.
Thank you,
Thanks.
Doctor. So, Dr. Gu, are you using hydroxychloroquine as azithromycin? Dr. Gu?
Yes.
Dr. Gu, yeah.
Yes.
Your experience with hydroxychloroquine and azithromycin?
We do not use we did use the hydroxychloroquine in our institution, several hospitals here.
And
but,
good.
The result, we don't know.
Okay. Dr. Coimbra?
So our treatment protocol includes hydroxychloroquine, but not azithromycin for the reasons Dr. Barrera mentioned. The combination of azithromycin and hydroxychloroquine, at least there are some cases that have been reported of the development of fatal arrhythmias because of the increasing QTC related to azithromycin, pre-use of azithromycin prior to hydroxychloroquine. So we felt that combination is actually dangerous, and we dropped the azithromycin. And if somebody needs to, if you feel that the patient needs to use antibiotics for bacterial coverage, our protocol switch azithromycin to doxycycline.
I have a quick question. A question for Dr. C. I've got the experience. Any experience with interleukin-6 inhibitors? Seem to be mixed results for us, and we do have 2 people here in our, at least in our region, that had dramatic improvement with interleukin-6, but these are anecdotal. I wonder what your experience has been, or Lee.
Yeah, it's the same. It's hard to say in any of these therapies because we don't have the numbers that New York has, or Italy or Spain. The experiencing with the antiretrovirals, anti-IL-6, and therapies for the cytokine storm are still at the early stages, and it's hard to say if people are improving because of those therapies or not.
I agree. I think the jury is still out on these treatments. We have the majority of our patients, or in either of the IL-1 or IL-6 trials, and we will at the end of the month probably. Seems that it's working, but they say it as of now.
We have we also have some same questions from last time because we have different audience and asking about convalescent plasma use. Have you used that much in New York? Any improvement with that, Dr. Barrera?
Yeah, we started using that as a trial last week. We only have a number of patients, and we still don't know, but we are using it, and it's a very cumbersome paperwork trial to do, but hopefully we'll have some answers in two weeks.
About Ken, about you guys in South Africa, Ken, have you use much of the convalescent plasma?
Negative. We do not have convalescent plasma. Frankly, we don't have the cases yet to justify it. So we do not have availability of convalescent plasma.
Okay. It is interesting that we mentioned the majority are using hydroxychloroquine, but there is more and more reports now coming out about the comorbidities and the side effects. Has anybody, apart from just Watchman, anybody seen direct side effects from your hospital, and what are these side effects? This was a couple of questions. Maybe.
So Michael,
yep.
This drug's been around for 40 years. For us from South America originally, we've known these drugs forever, and we know the side effects of chloroquine and hydroxychloroquine. High doses are toxic, and the problem is that the therapeutic window or the dosage is very small. It's very narrow. So if you increase the dose a little bit, you reach toxic levels very, very, very quickly. So obviously for COVID, nobody knows exactly if it's working or not, but it's important to emphasize that hydroxychloroquine may be okay, but chloroquine, at least the studies that have been published, do not show any positive effect. So if you're going to use hydroxychloroquine, lower doses to avoid the toxic effects.
Okay, thank you, Dr. Coimbra. So we are running out of time. I'm going to just put the last pool of questions so everybody answer. Then I'm going to have Dr. Jafarian, he just joined us back, just to comment on the last answers. And then we're going to continue next week. Next week, we're going to have a lot of talks about, we're going to have the physician from Milano talk about necropsy results. I'm going to talk about thrombolysis, etc. So Valeria, quick launch the last pool of questions, please. And then we're going to have Dr. Jafarian to make your comments about treatment. So, number one, are you using anti-IL-6 therapy? Yes or no? And how are the patients on this therapy respond? So I think the ones that are using this are going to give us a good answer. Number three, are you treating COVID patients with convalescent plasma? That's the next question. And number four, how are the results of using convalescent plasma? How are the response for these patients? Are you treating COVID patient? Number five, are you treating these patients with prophylactic anticoagulation? Yes or no? Are you treating these patients with full anticoagulation? Okay. Number seven, are you using lopinavir, ritonavir to treat this kind of patients? And how are the results? And number 9, are you using ribavirin to treat these patients? And do you know the results? Okay, so some good questions here. I'm not going to have time to answer all, so I'm going to have Dr. Jafarian to comment on his experience on all this treatment. And next week, for sure, we're going to spend a lot of time on the treatment options, going back to the chloroquine and going back to all this question from this last pool. Okay, so let's see, a few more seconds for everybody. Okay. 10 more seconds. Okay, let's close the pool, please. Valeria, and now Dr. Jafarian, you can go over the answers and just tell your experience on all this treatment that you just answered here, please.
Can you hear me?
Yes.
Okay, let's go to the first question that are you treating with the patient with interleukin-6 metrocilizumab or not? As you see here, there is again vast diversity between the answers, and 27% are using it. In our experience, some of our colleagues, because it wasn't question and answer, some of our colleagues had problem with a worsening of respiratory failure after tocilizumab. So it is not usually used here, just under some trials. And as you see, 39% are not sure about that. And the second question, how does the majority respond? As you see here, the response is not overt to be good. Even slight improvement or significant improvement is not too much. And most of the people, of course, have not experience with that, 60%. So it is just, again, I think that should be made decision after trials results are at hand. And then about the convalescent plasma, as you know, several countries have used this treatment method, and here we have 30% positive response for that. As far as I know, in Tehran, 3 centers are doing this now, and some of them have good results, and they are using it as one of the options for severely ill patients. But here, as you see, 43% of respondents has said no about that. And if we go to the question number 4, about the response to the plasma, you see that there is no overt good response. And I think this is the pattern for all of the drugs and the treatment methods that we have had in these polls. In different questions, we have the same answer, that there is no significant or somehow significant response. And about the prophylactic anticoagulant, as you see, 60% are using prophylactic. The prophylactic type is much advocated, and just 14% are not using as a prophylaxis. And the treatment dose is somehow under debate. 1/3 are yes, 1/3 are no, and 1/3 are not sure of the respondent. The other one is lopinavir and ritonavir, which is the Calitra. Again, we have 26% using it and 34% not using it, and 40% not sure about that. Again, we have the same response when we go to the question number 8. As you see, slight improvement is 10%, no improvement or worsening is somehow 5%, and most of the respondents have no experience of that, or they are not using it. And on question number 9, ribavirin, the positive answer is just 14%, 43% are not using it, and 43% are not sure. As I said here, again, it was used at the beginning of the epidemic in Tehran and in our hospital, but soon it was not proved not to be so effective as you can see here. And again, about the response rate, we have just 3% of slight improvement and 1% of significant improvement. So all in all, I think this poll again was a clue that no specific significantly influencing drug is at hand now. Just we have to deliver the best intensive care for the patients who are severely ill, and in that light, we have had some success. I hope that we would have one of the drugs of significant benefit for all of our patients.
So you have the same feeling, right? There's no consensus on the treatment. Dr. Barrera, your comments, you treat a lot of patients, discharge 1,000 patients, your comments on all these treatments and your experience, please, your feelings. You're muted.
Does it work?
Now.
Okay, I think the jury's still out with what works and what doesn't. I think we will not use azithromycin anymore. I think we will continue with hydroxychloroquine usage. I think we will continue to prone. There's very good data there's some data to suggest that the serum will work, and I don't know if the interleukin 1 and 6 will continue to be used. I think what's going to happen, in my opinion, it's going to be very patient specific, depending on what the patient has when he comes in. The diabetics are going to be treated very differently than the hypertensive or the ones that have intrinsic lung disease. We'll see. We'll never see this in the next epidemic.
Thank you very much. So next week we're gonna the guys from Italy back talking about the results of necropsy, and gonna have good discussion. So, and we're gonna go back to treatment again. So now, Dr. Aboutanos, I'd like you to ask our panelists to give your final comments and remarks, and then we're gonna talk about next week. Dr. Aboutanos, please.
So I was going to say thank you for all the comments. We just want to afford a few minutes because we're running out of time from each of the panelists. If they have any last comment that they thought we need to state before we are able to close the session and announce next week's session. So does anybody, whether Dr. Bofar or Dr. C or Dr. Guo?
Yes, I will have a comment. We should talk about the acute renal failure associated with the COVID-19 because it's not a topic they would talk about. Maybe we can talk about that next time. In terms of therapy, intermittent renal replacement or continuous, and what about coagulation things? What about patient in prone position? What can I do?
Okay, thank you. Dr. C, any specific comments?
No, I don't, but I just wanted to thank you for everyone. We are actually learning from what's happening across the globe here in New Zealand as well. So experiences that you guys have had managing these COVID patients is very useful for us to learn and set up our own protocol here in Australia and New Zealand. Thanks, everyone.
Great, thank you. Dr. Bofar?
Nothing to add. We're in the early days yet, but I do look forward to looking at how an early lockdown progresses. And one of the other things that is occupying a large number of people is how do you unlock down?
Yep, good point. Going back to Dr. Marttos.
Dr. Cohen, any other comment, sir, please?
I just want to thank you and Dr. Aboutanos for putting this together again. I think it is an important initiative. For next week, I hope after we see the results of the autopsies, we can talk about microthrombosis, because I still believe that the reports that are saying that patients that have been fully anticoagulated and a few patients that have been treated with TPA and have improved significantly are probably secondary to addressing the issue of pulmonary microthrombosis and also microthrombosis in other organs. And I truly believe that heparin is a potent anti-inflammatory in addition to being a potent anticoagulant. And I think heparin has a role here. So I would love to discuss that next week. Thank you.
Perfect. Yeah, this is going to be the focus for next week. So I have great data from Italy. They share with me some some news. So going to be a very interesting discussion next week. Dr. Jafarian, thank you very much. It was an honor to have you presenting today. Great data, great information. Thank you.
Thank you, and all the panelists for the question and answers. And just one point, if I have 1 minute. There was a question about the favipiravir complications. We have had some acute kidney injuries. We cannot say that it is of that or not, but that was in the trial was one of the problem. And also for tocilizumab, we had some worsening of the respiratory situation in the patients who were started on that. So that was a question that should we do it, or if we are going to administer it, we should do it earlier and not in the very bad situation. Thank you very much.
Dr. Barrera, thank you for joining us again, and I hope we can see you next week.
I'll be next week. We have a couple of autopsies that I can share the results also. Very interesting. I'll be happy to.
Great. I'd like to say thank you to Valeria and Gary. They have been amazing putting this meeting together. And to say also that the Panamerican Trauma Society, the American Association for Surgical Trauma, the World Coalition for Trauma Care, University of Miami, Virginia Commonwealth University, they are doing a great job sponsoring these meetings. And this recording of this meeting is going to be posted on the website tomorrow. Thank you very much. Stay safe and see you all next week.